Hello, sir. Am I audible?
Yep.
Good evening, everyone. I am Arpita from the IGCP group, and I welcome you all to this webinar on the topic Managing the Unstoppable Thyroid. That is a case based lesson in hyperthyroidism. And yes, to address the topic, we have with us someone very eminent from the field of endocrinology, Professor Dr. Arpandi Bhattacharya, sir. It's an honor for me, sir, to welcome you to our platform and to introduce sir to everyone. Sir has done MD in General Medicine, DM in Endocrinology, DNB Medicine, MRCP, CCST in Internal Medicine and Endocrinology, FRCP. He is a consultant endocrinologist at Manipal Hospitals, Bangalore. He is a professor of endocrinology at JJM Medical College. So, with this introduction, sir, now I would request you to please start with the topic for today. Over to you, sir.
Good evening. Thank you, Ankara. Thanks very much. Thanks for inviting IGCP platform. I am audible and visible. Slides are clear.
Yes, sir. Yes, sir.
Slides are clear. I am audible and visible.
Yes, sir. You are audible, visible, and
Yeah.
slide is
Okay.
also very clear.
So next around 20-22 minutes, I'll be taking you through the topic which is given to me for discussion, that managing unstoppable thyroid, the case-based lesson in hyperthyroidism. Now, I do talk about some cases, but my idea is to give you the concept so that tomorrow when you see somebody, what will be our right approach to reach the correct diagnosis. A little bit of a disclaimer that I do not have share in the pharmaceutical industry. I did participate as principal investigator in some of the trials. You have heard the names before. This session is not a sponsored one, and I certainly take the responsibility of the text of my talk. There are some photographs for the educational purposes are there in the presentation, but I have the consent of the people to show their photograph. So when we are seeing somebody in this topic, hyperthyroidism / thyrotoxicosis, our standard approach should be a functional, then anatomical and etiological approach. Functional means the function of thyroid gland is giving thyroid hormone. So this person's thyroid hormone is more. So what are the clinical and the biochemical test? Anatomical means irrespective of the functional overactivity, whether this person is a goiter or not, and if there is a goiter, it is creating any problem or not. And then most importantly, which will decide about the mode of therapy as why this person had an overactive or hyperthyroid state. But before that, let's just quickly see about differentiation between hyperthyroidism and thyrotoxicosis. Now, some people may think that it doesn't matter a cat is black or white as long as it catches mice. That's an old English saying. And to prove this or disprove this, I'm going to show you two quick cases. Okay, the first one is published in Postgraduate Medical Journal nearly 25 years back. This is a lady of 28, para 2, gravida 0, which means now is not pregnant. Last childbirth 2 years back. Presented with 8 months symptom of irregular period, shortness of breath, hemoptysis, and weight loss. On examination, we'll see what are the examination features, but this lady's examination, there was a stare with a lead leg, there is a tremor in outstretched hand, hands are warm and moist, there is tachycardia, tachypnea, there is no goiter. Now, when you have done this blood test, which showed raised T3, raised T4, and suppressed TSH, which makes the diagnosis of thyrotoxicosis or excess thyroid hormone in the blood. And the X-ray shows the cannonball appearance. Did you get the diagnosis? This is the case of choriocarcinoma. When you have done the beta HCG, it was 1,25,000. See, another gentleman. This is a man of 68, has diagnosed with a Graves' disease for 12 years. He was not responding well to antithyroid drug, so he was sent for radioactive iodine treatment. But he refused with the word of radiation. Then the plan of action was surgical treatment. 3 times he was admitted for thyroidectomy, and the morning before surgery, every time he takes discharge and gone, because he saw a dream in the black big man is taking a sword and cutting his throat. So ultimately, he refused surgery. He also reacted to carbimazole. So then she was on PTU, 4 tablets a day, which makes around 200 milligram. And we all accepted this is this gentleman's treatment going to be. So little bit dose up and down goes on, and currently he was on PTU. Unfortunately, he made a rare road traffic accident for which he was operated under the orthopedics department under general anesthesia. 10 days after the operation, he was detected to have a severely thyrotoxic, and hence the endocrinology consultation has been sent. When the blood test was done, it showed a total thyroxine more than 300 nanomole. T3 is normal, 2.2, and TSH is suppressed. You know what happened? Why this person has become thyrotoxic, severely thyrotoxic? Solution came when he came to know that he was given 200, but not milligram, in microgram. When he was clubbed by the junior resident of the orthopedics department, he was asked, "Do you have a thyroid problem?" Well, yes. How much tablet you are taking? 200. So this person has put on thyroxine 200 microgram. So one hand, he had a stress feature. Second hand, his PTU has been stopped. And the third point is huge dose of thyroxine given. And that's what the patient developed of thyrotoxicosis. And this lead was actually here. You can see this. You can see this. Thyroxine was way high. T3 was not very high. Okay. So we realized we stopped thyroxine, restarted PTU, and obviously there was a remarkable improvement. So when you're talking about thyrotoxicosis and hyperthyroidism, the defined thyrotoxicosis is the clinical syndrome due to excess circulating thyroid hormone. But hyperthyroidism, when this excess circulating thyroid hormone is being produced from the thyroid gland. So which will mean that all hyperthyroids are thyrotoxic, but all thyrotoxics are not hyperthyroid. Hence, the old saying of it does not matter the cat is black or white as long as catches my is probably wrong. It does matter even with the similar symptoms of thyrotoxicosis. What is the etiology? Because your treatment will depend on that. With these two cases, we quickly move on to our topic. But again, to remind on that point that there are certain situations where thyrotoxic but not hyperthyroidism. For example, case of thyroiditis. We tell thyroiditis with transient thyrotoxicosis because inflammation, the thyroid capsule releases all preformed hormone. You may have iatrogenic thyrotoxicosis or factitious thyrotoxicosis, the one given case I showed you, the elderly gentleman. We can have iodine-induced thyrotoxicosis, cough syrup or contrast agent. We can have an excess HCG or TSH, excess HCG you have seen. So those are things we need to remember. Even if they are not very common, our treatment line will be completely different. Now let's move down. Let's move to a simple approach to a patient with thyrotoxicosis. Now onward, I will use both the term thyrotoxicosis and hyperthyroidism as interchangeable. So I told you the first one is functional. In the functional, first is the clinical symptom. And these are the common clinical symptoms, or top 5 symptoms and signs of thyrotoxicosis. Weight loss, palpitation, increased sweating, feeling warm, loose motion. Actually, it is a hyperdefecation. It may not be loose motion, but increased frequency of the bowel. In the signs, we have tremor, tachycardia, goiter, stare, and warm, moist pump. This is exactly what is being told by British clinician, that face of a secretary on a Friday evening. You see, their working style is Monday to Friday. So Friday evening, secretary is very excited that I have a long weekend. I'm going to go out. So this is as if they are all the thyrotoxic. That is a scoring system was there to diagnose with thyrotoxicosis. It is called When Crookes Index. Long time, maybe it started the 40 years plus. We are not using that, but just for research purpose, if you see some objective point so that you can do the statistics, then you can follow the score. It is available easy in literature, and you can put the points and then plus and minus. You see the total score, and then you come to the point whether they are mild or moderate or severe thyrotoxicosis. Not to forget, there may be some atypical feature of thyrotoxicosis. Rarely, patient may present with weight gain, abdominal pain, elderly people with loss of memory, body ache, and also apathetic hyperthyroidism, which is again more common in elderly people. They are adrenergic symptom like a tremor, sweating. Their tachycardia is less, but they are got one of the cardiac symptoms, cardiac disease they present. After the clinical feature, we need to diagnose biochemically. So we do a blood test, we do TSH and thyroid hormone. So this is a hypothalamus pituitary giving TRH, TSH, stimulating the thyroid gland to produce T3 and T4, which is a negative feedback balance. Now, if you have a primary problem, we tell the thyroid gland is the problem. Secondary, we tell hypothalamus pituitary is the problem. Initially, we used to tell tertiary as hypothalamus, secondary as a pituitary, but we club together because there is not much clinical difference between separating between hypothalamic and pituitary disorder. That's why we tell now hypothalamo-pituitary disorder. So primary in the thyroid, secondary in the hypothalamus and pituitary. This is again a simple cartoon. Say x-axis you have thyroid hormone, that's normal, low and high. In y-axis you have TSH, normal, low and high. So normal person should have a normal TSH and normal thyroid hormone. But what we are discussing today, we are talking about primary hyperthyroidism. Thyroid hormone will be high, TSH will low. This is what we are looking when we are doing a biochemical test. And the test usually we do TSH and free T4. There are a lot of situations where the binding protein is much more, thyroid binding globulin, like people are taking oral contraceptive pill, pregnancy, then the total hormone can go up, but free hormone remains normal. So that's what we do a free T4. That's the best one. Thyroid testosterone fast is the TSH and free T4. Rarely, very rarely, we can see a T3 toxicosis where your free T4 can be normal, but free T3 is raised. Also, it can have some implication of iodine-induced, amyloid-induced thyroid disorder. But this is a rare situation. If you're commonly doing the biochemistry of the thyroid assessment, we will do a TSH and free T4. After the functional, we'll move to anatomical. Again, anatomical, we see the clinical feature and then we see the investigation. What we try to tell anatomical, this person is a goiter, person is thyrotoxic, it's goiter. What is the anatomical problem? What is the goiter causing to her irrespective of thyroid function test? So the clinical features, the typical formula, you remember our MBBS days, dysphonia, pressure on the recurrent laryngeal nerve, dyspnea, pressure on the trachea, stridor, pressure on the trachea, dysphagia, pressure on the esophagus. Is the big goiter. And then ultrasound. Ultrasound scan actually is not needed for the goiter. Clinically, we should be able to find out what's the grade of the goiter, what is the whether diffuse or a nodular goiter. But there are some goiter who are small nodules and small. We can do a goiter, but also ultrasound. But sometime for a cyst or a thyroid abscess, we need an ultrasound. CT scan, neck and superior mediastinum, we need to see the retrosternal extension because ultrasound does not penetrate the bone. So we need to see that whenever in situation of a big goiter so that it helps us in preparing for the operation. With this, we'll move to the etiological diagnosis. So remember, functional, structural, anatomical, then etiological. Now, common causes of hyperthyroidism are Graves' disease, toxic multinodular goiter, multiple nodules, and solitary toxic nodule. Other causes, as I was talking about thyrotoxicosis and this transient thyrotoxicosis and thyrotoxic factitia and so on. The reason we need to do etiology because when somebody comes to you with a thyrotoxic symptom, you will diagnose with the biochemistry, you will put them on anti-thyroid drug and beta blocker for around say 6-8 weeks. But subsequent treatment will depend whether this person has a Graves' disease, or a thyroiditis with thyrotoxicosis, or a toxic nodule or toxic multinodular goiter. And that is the reason everybody's initial assessment, you need to think of why this person's thyroid is overactive. Okay. So clinical feature, we can see an ophthalmopathy, dermopathy, or ophthalmopathy, we mean it uh, infiltrative ophthalmopathy. You see these two picture. It can be unilateral, start usually because bilateral later. Is very clear. This is an infiltrative ophthalmopathy. Just a stare is not good enough. Is another power person who got the tarsography operation, as you see this. And this is what the dermopathy. Usually, it is more seen in Caucasian. Why, I don't know, whether because of color of our skin we diagnose late or we don't diagnose, but it is much more common. We have seen some cases, but it is very rare, less than 1% of the Graves' disease. And this is one of our patients, which is a biopsy proven thing. But anyway, as you see this picture, it looks like I'm digging into the diagnosis. Actually, it was a biopsy proven dermopathy, pre-TB myxedema. Important is an antibody test. Now, whether important or not important, you see, we have three antibody: thyroglobulin antibody, thyroid microsomal antibody, and TSH receptor antibody. Now, thyroid microsomal antibody, thyroid globulin antibody is done commonly and unnecessarily. Most of the cases we doesn't have anyway, because the general population up to 25%, in relatives of the people with autoimmune thyroid disease up to 50% kind of positive. It doesn't help. In this context, if anything helps, that is TSH receptor antibody, which is little costly, which is a good diagnostic marker, and also helps subsequently in different clinical situations, including pregnancy, Graves' disease, and stopping of the medical therapy. And if done correctly, nearly 95% will have a positive TSH receptor antibody. Fine needle aspiration cytology. Please do not do anybody in thyrotoxicosis. The gland is very vascular. You can produce in hematoma. We have seen in clinical practice 100% proven that FNSE produces a hematoma. The patient needs an urgent exploration. Please do not do, because a thyroid cancer does not become toxic. That is a common dictum which is probably right. You will have to be very, very rare situation that you will find my statement is wrong. So a blind no for fine needle aspiration cytology when somebody is thyrotoxic. The things remain isotope scan. Now that is very helpful. If you do an isotope scan, this is an isotope scan of a normal thyroid. You see the thyroid gland, both lobes pick up, and some amount is picked up by the salivary gland. But if your etiology is a Graves' disease, all of these isotopes will be taken up by thyroid gland and nothing will be left for the salivary gland. So that confirms the diagnosis of Graves' disease. In thyroiditis, as opposed to that, gland is inflamed and doesn't take anything here, and everything is been taken by the salivary gland. So you see the common picture, and this is very, very important to differentiate between thyroiditis and Graves' disease, because your treatment line will be completely different. That's what I wanted to show is this picture. Why bother about etiology? If you have a nodule, toxic nodule, that's called a hot nodule, everything is picked up by this nodule, nothing left for the rest. And it can be a multiple hot nodules, so which is called a toxic multinodular goiter. And that's why isotope scan is very, very helpful. It's a technician isotope scan. I think it is reasonably available most of metro, two-tier city, three-tier city, and so on. Just a bit word, when we are talking about thyrotoxicosis, there is a term called thyrotoxic crisis. It is rare because we pick up them and early treat, but there are some precipitating factor. If you take for operation or give a radioactive and uncontrolled thyroid patient, they go to crisis, infection, radio contrast agent, because iodine containing, they act as a fuel and the fire. You are giving fuel to the fire. It's a real emergency and treatment requires multi-pronged treatment. That's we are not going to discuss today. So my approach of this simple approach of thyrotoxicosis: functional status, what is the gland producing thyroid hormone, what are the clinical picture or the blood test documentation. After document functional status, we see there is a goiter or not. If there is a goiter, we go along that line. And then we see the etiological thing and whether it is a Graves' disease or thyroiditis or a toxic nodule or toxic multinodular goiter. I'm not going to discuss much of the treatment, but again, this concept I wanted to put. Initial treatment, controlling beta blocker, controlling T3 refers steroids, particularly for thyroiditis. Subsequent treatment, if there is a Graves' disease, as you have seen the isotope scan, we have a medical treatment, surgical treatment, iodine treatment. If you have a thyroiditis, mainly observation with a beta blocker, maybe small dose of antithyroid drug. Painful thyroiditis, you can use a bit steroid. And if it is a toxic nodule or multinodular goiter, we need to ablate the nodule or ablate the multiple nodule, either radioiodine ablation or surgical ablation. So, in conclusion, a systematic approach to diagnose thyrotoxicosis is important. At the beginning, prove it is hyperthyroidism, not thyrotoxicosis, even if only thyrotoxicosis is a bit rare. And etiology is a very important for the correct treatment and to go in the correct direction. I'm going to stop here. Thank you very much for listening to me, and I'll be happy to if you have any question or anything to tell. Yes, Ankana, I think I am okay now.
Yes, sir.
I will stop share now. Then I can see you people. Eh?
Yes, yes, yes.
Okay. Yes, I can see you. Yeah.
Thank you, sir. Thank you so much. It was such an insightful presentation. And sir, meanwhile, we have also started receiving some questions.
Yeah.
Sir, the first question is from our YouTube viewer, uh, Mr. Anwar. He wants to know what are the role of propranolol in managing shock thyroid.
In managing
Shock thyroid.
overactive thyroid, managing hyperthyroidism. That's correct, no? So this is a beta blocker because first symptom is an adrenergic symptom. The circulating thyroid hormone, when they're extra, they act on catecholamine receptor. So by using the propranolol, we are blocking that action. So this is not going to do anything to the thyroid, but it is going to reduce the symptoms, adrenergic symptoms like a tremor, like a sweating, like a palpitation, because whenever giving thyroid hormone it will take some time, few days or 1 or 2 weeks. So that's why immediately we start a beta blocker, and it does not interfere in any of the investigation that you are planning to do to find out the etiology of the hyperthyroidism.
Right, sir. Thank you so much. The next question is, sir, how do you manage hyperthyroidism in special populations such as pregnant women or elderly patients with comorbidities?
Right. Elderly people, whatever way you define, whether 65 or 75, anti-thyroid drugs are very safe. There is no harm. Now, you can continue a small dose of anti-thyroid drug, even if toxic multinodular goiter, toxic nodule for long time, including decades. Surgery can be a problem because of the age and because of the comorbidity. So, unless we are pushed further, we will not be going to the surgical option. Radioactive iodine is a perfect treatment for the elderly. Absolutely no worry about that. So far, the pregnancy is concerned, it is a Pandora's box. Now, situations are like this. At the age of say around 30 or 25 to 35, then most of our women are pregnancy age. So you are not thinking much of toxic adenoma, toxic multinodular goiter. That is a bit of a elderly type, 40, 50 plus, or older adult. Now, here, your commonest diagnosis is Graves' disease. Now, if you find a thyroiditis with a transient thyroiditis, the situation is not difficult. You can finish it up treating within 6 8 weeks. That's fine. But the question comes to the Graves' disease. Now, again, we will divide in two groups. One, before conception, they are diagnosed as a Graves' disease. Second, in pregnancy, they are diagnosed as Graves' disease. Now, before conception, if you find somebody have diagnosed Graves' disease, the best is that to make euthyroid completely before conception, because chance of miscarriage and other problem, the pregnancy, neonatal problem can happen. Even they can go to thyrotoxic crisis in the pregnancy if there is not very well controlled. So you treat the line whichever I told, whether medical treatment or iodine treatment or surgery, it is the best option that you treat everything and then allow her to become pregnant. Question will come when they are diagnosed in pregnancy. So in pregnancy, out of the three treatment, radioactive iodine is out. We can't give it. Forget about that. Now, our option is surgery versus medical therapy. Now, surgery, if the medical therapy is difficult, surgery, technically, theoretical, is an option in the textbook, but in my personal experience of endocrinology by around, say now it is 33 years, I have never seen, forget about me saying, I have never seen a doctor who required a surgery on a pregnant woman for Graves' disease. So it is that rare. We don't need to think of that because our medical therapy and the monitoring is so easy now, we can nicely manage. Now we have two medicine, okay? One is methimazole, carbimazole, one is PTU. Now question is which one to give it. The main difference between these two is that PTU is more protein bound. So if you are, suppose somebody told you in the breastfeeding time which one to give, PTU will be preferred. But in the pregnancy time, most of the time we'll be giving a bit of methimazole. A standard practice is that you give first trimester propylthiouracil, and beginning of the second trimester you change it to methimazole. This is that most of the guideline tells, although the supporting data for the evidence-based medicine is very, very less. The reason we stop PTU because hepatic dysfunction as a side effect of antithyroid drug is little more common in PTU than in methimazole, carbimazole. And also, you remember we need a very close monitoring, definitely one biochemistry every 4 weeks. And usual observation is like all other autoimmune disorder. As the pregnancy advances, your dose of antithyroid drug comes down. Most of the commonly in the third trimester, you do not require any antithyroid drug. But there will be a chance of postpartum relapse. So 2 weeks after delivery, again, we need to check the biochemistry. This is a bit of a nutshell about the pregnancy management of the thyroid.
Right, sir. Thank you so much for giving us such elaborate answer. And moving on to the next question, sir. Sir, especially in patients with grave disease, what is your perspective on the emerging role of newer therapies such as the biologics or targeted therapies in the management of hyperthyroidism?
Well, the targeted therapy, what is there at present, which we are using, which is very costly, which you can use, not we are using, I'm telling, that is for only for Grips ophthalmopathy. We are not using anything like an immune checkpoint inhibitor type of thing in people with a standard hyperthyroidism or the Grips disease because not only the cost, the side effect profile, monitoring, everything is much more difficult and there is no extra advantages there. Main the therapy what you are talking is for the Graves ophthalmopathy. We are not able to use quite a lot. The main medicine which is available, which cost around 1.5 lakh per injection, which has to given at least around 6 injection. It becomes a hugely costly. So our standard line of treatment, if you have a significant Graves ophthalmopathy, we control the thyroid, give a pulse steroid therapy to reduce the inflammation, and when the inflammation subsided, if there is any scarring, some sort of a corrective surgery. So at this point, for us, antithyroid drug.
Right, sir. Can we take one last question?
Yes, please.
Sir, what are the key factors that contribute to the failure of a conventional treatment in case of refractory hyperthyroidism?
Yeah, this is actually a good question. Now, this question will come when the etiological diagnosis is Graves' disease. Okay, so we will not tell a refractory treatment for toxic adenoma or toxic multinodular goiter because there you need to ablate the nodule or nodules either by surgery or by iodine. So this question comes from the Graves' disease. Now we have some identifiable factors are there which has been proven that they may not respond well to the medical therapy. Number one, very strong family history of Graves' disease. Number two, a big thyroid gland at diagnosis, huge goiter with Graves' disease. Number three, very high titer of TSH receptor antibody, very high titer. Number four, a T3 toxicosis. A small group of Graves' disease can have T3 toxicosis where T4 is normal but T3 is high. Actually, they do not respond well to the medical therapy. So these are the four category I can remember when I see first time in the patient. In back of my mind, I keep okay. This person may not go to remission with only medical therapy. So when our follow-up, we can tune slowly, slowly to him or her that this is where we are going and this is what probably we are going to suggest you. Definitely other therapy like an iodine or a surgery.
Right, sir. Thank you, sir. Thank you so much for answering all the queries that have come from our audience. And so, before we wrap up, I would like to thank you for such an insightful presentation on this very critical topic. So, your case based approach provided valuable lesson for tackling complex hyperthyroidism cases. I really appreciate your time and your expertise. So, thank you so much, sir, and thanks
Thank
to
you very
all
much.
our audience.
Thanks.
Thank you, sir. Thank you so much. It is our honor. And thanks to all the audience for joining in and making the session an engaging one. Thank you all. With that note, I would like to end the session here. Thank you so much.